Hi, I'm Natalie Clay, the clinical informatics nurse for PHH, and we're going to be talking today a little bit about your clinical documentation as it pertains to the new homeless discharge tab, heparin drip documentation, pain reassessment, and home medications upon discharge. All right, so one of the first things I want to talk about is the new state requirement that came out last year. And that's for the regulatory requirements when discharging a patient who is homeless in the hospital. And when you go to your discharge assessment, you're going to see a new tab that was added to help you meet those requirements. One of the biggest struggles that everybody has is really determining what the definition of homeless is. And according to the state of California, that definition is the location or address that the patient identifies as his or her residence or desired discharge location. So I'm going to talk a little bit about what that means. There are patients who desire their discharge location to be, let's say, at a park or in a car that they want to stay at a certain beach location or whatever that may be. In that case, the patient would not be considered homeless, as that is their desired discharge location. However, if we have a patient who does not want to be in the circumstance that they're in, they fell upon hard times, they have nowhere to go, they're sleeping in a car, not by choice, that person would be considered homeless. So your first task is this top box on the screen for home status. You're going to determine, is this patient truly homeless, or do they have what the state determines to be a fixed regular residence? So once you answer or ask that question to the patient, you're going to then click the box homeless or that they have a residence. If they have a fixed regular residence, you're essentially done with this particular discharge tab in your discharge documentation. You can simply put the location, even if it's street corners or a store parking lot, an address or location that the patient identifies as their residence. You'll type that in here and you're now done with the tab. However, if the patient is homeless, you're going to check the top box, that's this box here, and you will proceed to complete the remainder of the screen. Everything that you need as far as your regulatory requirements are contained in the documentation. So the first question is, physician has performed an examination and determined that the patient is stable for discharge. You'll answer yes or no. The patient should be referred to follow-up care if they're homeless for both medical and or behavioral health care. If you get that referral, you need to make sure that you're placing the referral physician information and documentation. You also have the responsibility to assist the patient in finding a place to go, and that is the community resources and placement options. There is a packet provided by case management that you should have in your unit or area. If you do not have that, please contact case management to get it. It has a list of all of the places that we can call that the patient can go to for free. We have an obligation to make those phone calls and not discharge the patient until we find a place for them to go. The three primary are room and board. Those are free. Shelters are also at no cost. There are other resources located in the book, which would be your other box, and those typically require some kind of funding, and you would want to contact case management. Once you have done that, we also need to document the fact that we have assessed the patient for appropriate clothing upon discharge. That just means not sending them out the door in the middle of winter with no shoes. We have a donation closet. You are responsible for getting the patient clean clothes that are in good condition and weather appropriate. If they already have those, you can document that they have those on their person already. We also are required to provide a plant-based meal. Our dietary department does have prepackaged meals that meet the requirements needed. Transportation for discharge, we are responsible for providing discharge up to at least 30 miles from the facility should the patient want to go that far. And please use our request from the house supervisor, a bus, taxi, or voucher, or that the patient has refused any further transportation. Once you're done, you can yellow arrow and get out of the screen. It is a requirement for all discharge. That includes discharges on the inpatient side and all discharges from the emergency department. Once you've completed the discharge assessment for the patient, you're going to want to go through your patient profile, discharge list of home medications. You want to make sure that whatever the physician has done for medication reconciliation is actually matching up to what's in patient profile, as the patient profile list will become what is printed on the patient discharge instruction that we send patients home with. To do that, you're going to come into patient profile and go to their home medication list and simply review each medication on that list. You're also going to want to verify that the last dose taken has populated in this column here. The last dose taken is the last time that the medication was administered in the hospital. That will pre-populate on most of the medications if they've received them. However, some patients are continuing medications that they had at home prior to admission, and they did not receive that medication in the hospital. If that's the case, they may not have a last dose taken present on the screen. You want to just make sure that anything they have received in the hospital and will be continuing at home has that date and time so the patient knows when to take the next dose once they get home. After that, if there's anything that looks like a discrepancy and should not be on the list, you'll simply go to the pencil icon to the left of that medication, and you'll open that medication up and take action on the medication. The action may be to make that medication inactive. For example, if it was an IV and we know that the patient is not going home on that IV, we can come over to the status section and we can simply inactivate that medication as a home med. Just make sure that everything here is as it's supposed to be, and once you're done, you are now complete with your medication list. Next, we're going to talk about pain and pain reassessment. And this is during the hospital stay. Your patient, when they first come in, all of the pain locations need to be initially documented in your pain assessment on the daily assessment screen. Once you get to the pain tab and you open up the pain assessment, you want to make sure when you're clicking a new location that you're filling out every area completely. You do have to the right-hand side of each item a small key or a lock that when you click that, it locks down that value so that you don't have to re-enter it every time you document your pain reassessments. So I would encourage that you use the key to the right-hand side to document everything with the exception of the pain score and potentially any interventions that you might be doing, as those are going to vary every time you do your assessment. So this is your primary assessment screen. This should be done at routine intervals, your initial pain assessment, during your shift assessment, and any other time that the patient requires a full pain assessment. For reassessments, you can come back in this screen and simply put the pain number, but you also have two other locations that you can perform your pain reassessment. All pain documentation, no matter which screen it's performed on, will all go to the same place and on the same reports in the medical record. So for example, if we are looking at your flow sheets, we'll go ahead and open that up, and you right click and say new, vital sign entry. Pain assessment will be located in your vital sign screen. You can put the pain score, the scale, and the location, and when you've already entered a location in the main pain assessment screen, that location will be here in the drop-down list, and then you can put your position modifiers as well. At that point, your pain reassessment is complete. Your pain reassessment can be done or should be done, again, with appropriate time intervals and per hospital policy and after a pain medication administration. You can also do a pain assessment with medication administration. That is the third location that you can document. You typically will not go back in there to do your reassessments, but you would be going into your MAR and documenting the pain level and location and position, just like you would on the other screen for any of your pain meds. Lastly, we're going to talk about documentation of IV drips and drips that require titration. Initially, when you get a new IV drip order, your MAR will look like this. They will have no due times for the medication, and that's because it's difficult to determine what rate the drip is running at if you're titrating. So the system doesn't know what time that bag is going to run out based on the rates that you're running it. So initially and consecutively, each time you hang a new IV bag, you will right-click in the field and you will go to Add a Titrate Administration. You will then document the date and time that you're hanging the new IV bag and say OK. Once you do that, a new administration bubble will show up on the screen for you to be able to document. Once you click on your green administration bubble or you do your barcode scanning of the IV bag, you'll have the following administration screen that pops up. You want to make sure that you are documenting the rate under the fluid information, rate and dose and starting volume here. This will also transfer over to your flow sheet for your IV documentation. So it's very important that you put those changes in this location for the fluid totals that your patient is going to get. Now, beyond the fluid totals are the dosage and titration rates going up and down that you're going to be doing on your patient. Those are not documented in this location as you titrate up and down after hanging the initial drip. The titration changes you will be doing in your other flow sheet, which is, and I apologize here for the delay, your measurement flow sheet. So your titration should be going in your measurement flow sheet. You will simply right click, say new, go to your measurements, and then find the particular drip that you're running in the drop-down list, and then you will place the dosage amount there as you make the rate changes. All right, so that concludes the clinical documentation portion of Skills Day for this year. If you have any other clinical documentation related questions, please contact the help desk at 5300. Myself and Melanie Sorensen, who is our other clinical informatics nurse, are available 24 hours a day, 7 days a week to answer those questions and to assist with your needs. Thanks, and I hope you guys have a great year.